Okay, thank you very much, and thank you guys for having me this morning. So, I will be talking about acute kidney injury. So I'll start with sharing the objective of this talk. So, we're going to talk a little bit about acute kidney injury epidemiology, and then specifically in children's, then we'll talk a little bit some of the risk factor of pediatric AKI. We'll talk a little bit about how we can prevent and maybe address some of different type of AKI. Then I want to focus a little bit on the outcome, why it's important that we recognize AKI and try to prevent it, and then a little bit of some new advancement in biomarker. So I'll start by just defining AKI. So what is acute kidney injury? So it is an abrupt loss of GF4. And that abrupt loss leads to retention of waste products, urea, distortion of extracellular volume, and electrolyte hemostasis. So that's the main thing. But again, the term acute kidney injury, there is the expectation of possible improvement versus when you hear like a chronic kidney disease or CKD, we know a lot the kidneys is not going to get better. So that's the main difference. But still, this term, we remember, and a lot of you read a lot of like older articles, and still to this day, sometimes not everybody agrees on the term. But you heard a lot about like renal failure and other acute renal failure versus chronic renal failure. Again, we try not to use that renal failure term anymore to describe acute injury. The idea is when people like when families or patients hear the term failure, it's just doesn't describe like the whole spectrum of acute kidney injury. So sometimes you have just mild elevation in creatinine, and that's still acute kidney injury. But if you're going to use failure for that, it's going to give the wrong impression about what we are dealing with. I mean, again, this term is still not perfect. So it still doesn't tell you what kind of injury you have. Is it like toxic? Is it ischemic? Is it like functional or what we call pre-renal, where the kidney is not seeing the blood volume, and that's why we have acute kidney injury? And again, it also doesn't talk at all about the other kidney function. So we always, when we talk GFR, we're talking about the glomerular function of the kidney. But as we all know, I mean, kidneys make hormones, have a tubular balance. That's help us a lot, like keep balance of a lot of substance in our body. So again, that term also does not include those things. But so far, I mean, as I said, this is the most agreed upon term for this type of injury. So I want to talk a little bit about definition. And again, over the years, even in the last like 10, 15 years, there have been various definition of acute kidney injury. Recently, most adult nephrologists and adult provider will agree on the KDIGO, and then after that, pediatrics follow, and we try to adapt what we call KDIGO, which is kidney disease improvement global outcome. Basically, it's an initiative of like multi-country trying to quantify, like to unify the terms we have. So as you can see, so this is the, I'm not going to say, but like you have based on serum creatinine and urine output, and we have 3 different stages for acute kidney injury. So this is very similar to the adult one, but I can see at stage 3, I changed, like I put this in red, which is the eGFR less than 35 ml per minute. And the idea is, if we just use this, sometimes for our younger patient, it may not be very accurate. Like if we're going to wait till serum creatinine is more than 4 for a newborn or a neonate to call it stage 3 kidney injury, that's not fair. Because again, I mean, their baseline creatinine could be 0.2, 0.3. So 3 times that, it's maybe less than 1, and you still have stage 3 acute kidney injury. So that's why the specific eGFR used in the pediatric calculation. And why this is important. So clinically, a lot of time you will see like we don't make like different clinical decisions based on like different criteria or different staging. But as you can imagine, like if you're doing any clinical trial or if you're doing any research study about AKI, you want to be able to talk about like different type of AKI or different, basically as I said, so usually the different stages, it may not change like what we do clinically. Like it may not change, like it doesn't have to do with like when do we start dialysis or we don't start dialysis. But again, it's just agreeing on like what's constitute like different severity of acute kidney injury is very important if you're doing research regarding acute kidney injury. So we know like different intervention or different things work for certain severity of AKI or not. So as most of us familiar with creatinine use, so this is the most common marker used to define acute kidney injury or to define kidney function in general. So we use creatinine, and as I said, most commonly, again, creatinine is derived from metabolism of creatine on the skeletal muscle. So the more muscle you have, you will have higher creatinine. And again, as any other marker, the main thing is going back to renal physiology, like you need the marker to be freely filtered and neither reabsorbed or metabolized. There is a small amount of creatinine secreted from the capillaries into the kidney. But again, that's usually constant amount, and that's why it's still not the perfect marker for GFR, but it's good enough and it's very cheap. That's we continue to use it this day. But I would like to talk a little bit about like why it's not the perfect marker. So as pediatrician, all of us we deal with this every day. So again, the less muscle mass you have, your creatinine will be lower. The more muscle you have, your creatinine will be higher. And a lot of time we'll see like we'll have even outpatient, we'll have somebody's lab like a creatinine that's a little bit outside the reference range for age. And we always have the question: is the patient is more muscular compared to like an average person for the same age, and that's why the creatinine is a little bit higher or not? And the same thing with our neonates. Sometimes you have very low creatinine production, even with kidney injury, your creatinine doesn't go up very high, and that could underestimate if you have kidney injury or not. The other important marker is how fast you have the relationship between creatinine and GFR. So let's say you have patients who have acute kidney injury. Do we see the change in creatinine right away? So you can see from this graph, it is not. So the relationship between serum creatinine and GFR is not linear. And I want to make sure, like, if you look here, are you guys able to see my marker?
Yes.
Yes.
Oh.
So I just want to make sure, like, again, the patient who have lower GFR, let's say one of my patients like have CKD stage 4 and their GFR is around 30. You can see like serum, it doesn't take even decrease from 30 to 15, your creatinine will go from 4 to 8. Versus when you have a normal GFR, let's say like 120 or to 100, it takes much more for that GFR to decrease before you have a creatinine. Like you can see it went from 20 to 60, and it's still you already have creatinine just jumping from 1 to 2. So again, this is also something we always have to be careful when we're interpreting creatinine. The other thing I wanted to talk about is like what we call the steady state of acute kidney injury. And again, this study is looking here at like serum creatinine on the X and with time. And again, the red squares you can see here, it's how it takes to double your serum creatinine. And you can see patient with CKD stage 4, I mean, it takes longer time to do that. But you can see even to double your creatinine, if you don't have any previous baseline kidney issue, you can see it takes up even to 10 hours before you start seeing raise in creatinine. And I always like to give, when I'm talking to the resident in nephrology clinic, like to give the example of why we can't use creatinine. Let's say, for example, my creatinine 1 and my GFR is 100, for example. And let's say magically I just removed my 2 kidneys and I check my creatinine an hour later. My creatinine probably will still be 1, even though I have 0 GFR. I don't have kidneys, so I have 0 GFR. And it's probably going to take at least like 8-10 hours before we start see any raise in creatinine. So that is very important. And again, it's hard, and we always get this question in the hospital, like from pharmacy. We had a patient whose creatinine has been increasing, and what's the patient GFR right now? Because we want to dose a certain medication based on the patient GFR. And my questions will be at that time, I can't know accurately what's the patient GFR, because all the calculation we have based on creatinine to GFR, they're on for the steady state. So that's like our CKD patients who have high creatinine for like period of time, and that's where we can use the creatinine. But if you have rapid changes, like your creatinine is going still up every day, we cannot use that like GFR, like estimated GFR from creatinine. I mean, I will always tell them, yes, the GFR is very bad. It's very low. Probably I will say less than 15 ml per minute, just because your creatinine continue to go up every day. And the same thing the other way around. So when your creatinine is improving, probably GFR will be like a creatinine will be also slower to come back to normal. So again, probably your GFR is better than what your creatinine is. And again, that's important because sometimes if you're dosing antibiotic or something based on GFR, the patient may clear the antibiotic faster than what expecting based on the serum creatinine. Again, so I give you like all of those things. We have some alternative. I mean, we have something called cystatin C. We have been using that more frequently. Again, it's not based on muscle mass, so it's produced by all nucleated cells. It's freely filtered from the kidney. Because it's not related to muscle mass, it's not very affected by age or nutritional status as creatinine. So again, there is some certain diseases that could affect it, like thyroid dysfunction, corticosteroid use, inflammatory disease. But again, for that example I gave in the beginning, if we have somebody and we're like a higher than average muscle mass or lower than average muscle mass, like patient with cerebral palsy, where we know they don't have the muscle mass compared to a patient with no cerebral palsy. So at that point, yes, we definitely could use cystatin C to get a better idea about the patient kidney function. But what we talked about, the steady state, it didn't change. So you still need a steady state to use cystatin C. So if we use it in the hospital in the acute settings to better estimate GFR, it's not going to be a big difference from creatinine. And cystatin C, we have normal values for even a newborn, neonate, and now even premature babies. So it's been used more and more even in younger patients. And the same way we have equation to estimate GFR based on creatinine, we have equation to estimate GFR based on cystatin C. And actually we have equation based on creatinine and cystatin C at the same time. And a lot of studies showed that is superior to just based on creatinine. So I use that in my chronic kidney disease patient when I know CKD patient may not, especially severe CKD, may not to grow as much. And I use that cystatin C in my daily practice. So since now we talked a little bit about the definition, we talked a little bit about some of the molecules we have to measure GFR. I want to talk a little bit about AKI epidemiology in children. So again, we don't know the precise incidence and prevalence of acute kidney injury. And it has to do a lot about what we talked about earlier. There is no one definition of acute kidney injury that's everybody use. So again, different countries sometimes use different things, different terms as used. And again, if you see like clinical trial, they're defining acute kidney injury differently. And that's why it's very hard to have a consensus of the incidence and epidemiology. But I would like to share with you some of the studies was like done here in the US about some of the epidemiology of AKI. So this one study, it was done, it's multiple children's hospital. They looked at almost 3.3 million kids, and they excluded every patient above 18. They and they looked of those like renal transplant patient and the stage renal disease patient that were excluded. And then this is the 2.6 million kids admitted in the hospital. And then among those admissions, they tried to see how many of them developed AKI versus did not develop AKI. And you can see out of 10,000, 1,800 developed AKI versus 7,800 older than 1 month of age developed AKI. So, but I want to mention that this studies was done on ICD codes, and we all know like ICD codes is not the best way to do studies for acute kidney injury, because again, people define it differently and they may assign the code even though it's not there. And a lot of time the main issue is the other way around. A lot of time, if you just use code, a lot of it is undocumented. So a lot of patients in different units in the hospital will have high creatinine. It will be a little bit up, still be considered acute kidney injury, but it's not going to be documented. So it's not going to be in the patient problem list. Uh, and again, we have recent study was done in one like children's hospital. It was something like sometime it's less than 10% of all AKI. If you look at the patient actual serum creatinine, sometimes it's less than 10% of all AKI are actually documented in patient chart, even at discharge. So it's not a part of their problem list on discharge. So this is another study. It's looking also 28 days to 21-year-old, and they looked at like many children's hospital. They had like 18,000 patients. They excluded CKD, and again, they're looking at the rate for ICU versus not ICU patient, and you can see also the percent of AKI. So this is how they define it. So in this study, they didn't use ICD codes, but actually used the KDIGO definition we talked about, which is 1.5 fold of creatinine increase or 0.3 milligram per deciliter increase. And you can see, so it's 59% of a critically ill patient had AKI, and then 31% of non-ICU patient had AKI. And you can see the big difference between the previous study and this one, like just using the ICD codes versus using serum creatinine for patient to see who got acute kidney injury or not. I also wanted to include for neonate, for the neonatologist and us, some of us who take care of the younger youngest population we have. So this study is done in, again, it's called the neonatal acute kidney injury collaboration. And basically it's included 24 NICUs around the country in North America, some of them in Canada as well. And they looked at all their admission. They tried to make it for certain population that's not very sick. So they actually like true NICU admission. So they excluded all patients who didn't get like IV fluids in the more than 48 hours. The idea is they didn't want to include patients who, like, let's say, got like a transient respiratory distress or transient hypoglycemia, got admitted to the NICU. They wanted to capture patients who actually stayed in the NICU for other reason. And again, you saw like congenital heart disease were excluded, chromosomal abnormalities, patients who died within the first 48 hours. And they looked at different gestational age, and they break down the percent of those patients who had AKI. We're all expecting probably that the lowest gestational age, the 22 to 29 weeker, to have the highest risk of 4DA. I mean, we know those patients are sicker, and that's definitely, there are higher risk for AKI. And then you can see 29 to 36 was a little bit lower, but then again, when you go above 36, it's high again. And the idea, probably if you're above, and that's what the conclusion of the authors, like if you are older than 36 gestational age and you end up being admitted to the NICU, probably that's just a sign of acute disease. So something has happened. So probably you are sicker than other kids that you end up being in the NICU, and probably that's explained why the acute kidney injury risk was a little bit higher. I want to just make a difference here so you can see how they defined. And again, the same KDIGO parameter we talked about to define AKI. When we're talking about neonatal AKI, we change it a little bit because as most hospital in the US will report like the urine output like ml per kg per hour, like for 24 hours, versus like adult older kids, we look at time at urine output for like every 6 hours or every 12 hours. So they changed the timing for the criteria to look at that 1 ml per kg per hour, which is most commonly used, just to try to to be more consistent with what we do in the NICU actually. So that's the reason you see the definition is a little bit different. They defined it as less than 1 ml per kilo per hour. So now we talked about the epidemiology of AKI. I want to discuss a little bit about the risk factor of AKI. And that's include, I mean, we know critically ill patients have higher risk of AKI. We know neonate have higher risk of AKI compared to older children. Nephrotoxin use, we always talk about this. And again, there are some comorbid conditions that could cause this. So I wanted to share with you this paper, which again talk about like the different risk factor. We talked about like a critically ill patient. So it had like 1,000 patients who had AKI, and we tried to break down different reasons. So we can see like cardiac patients have a higher risk of having acute kidney like a kidney injury. They use this pediatric index mortality score. Again, it's like a different scoring that used in the PQ. Again, it's include the need of pressure, need for ventilation, among other things. And we know like the sicker you are, the risk of acute kidney injury is higher. Vasoactive, so we know that the kidney is very sensitive to volume, it's very sensitive to perfusion pressure and to blood pressure. So again, it was expected. Yes, we know patients who's requiring vasoactive pressors are at higher risk for AKI as well. And then fluid overload. So again, it's hard to tell. I mean, they both lead into each other, so it's hard to tell like which one came first. But we know, I mean, fluid overload by itself could lead to acute kidney injury, and it by itself, even regardless of everything else, when you correct for everything else, it's increased risk of mortality for ICU patients. So I want to see. So this is a little bit different. So this is for neonatal patients. So just trying to look at what risk factor we have in our neonatal population that associated with higher risk of acute kidney injury. And again, inborn versus outborn, that mean outborn like a transfer to the hospital from another hospital. Probably if a neonate had to be transferred to other hospital, that means they're probably sicker, and that was associated with higher AKI. Again, it's the same thing. Epinephrine use, surgical need. We know those patients are at higher risk, and hyperbilirubinemia. And again, it was I was trying. They even the authors they were not able to pinpoint the exact reason, but it's probably related to possibly some pigment nephropathy. So and at the same time maybe dehydration with the hyperbilirubinemia. Like those patients were dehydrated when they got admitted, and that's maybe a risk factor for acute kidney injury. So this is just to show you. So we said neonate and like low birth weight is by itself a risk for acute kidney injury. So as you can see here, it's gestational age starting at 22 up to 37, and then no AKI with AKI. And then we can see patients with lower gestational age have significantly higher percent of acute kidney injury. So that happened 80% of patients experienced AKI were born less than 28 weeks in this study. And again, I think we see this on everyday practice when we see patients. The younger you are, usually the thicker, more intervention you require, you are a higher risk for acute kidney injury. So we talked about like different risk factor. We talked about why the neonate are a little bit at higher risk for acute kidney injury. Now, like nephrotoxin use. And again, there is plenty of study we can't see, but I chose this one to share with you because I always get that question about like NSAIDs. And again, the literature on NSAIDs use, it's always changing. But it is one of the most common reason why we have acute kidney injury and NSAIDs use. So you can see in this patient, like they had the 1,000 patients with acute kidney injury. Among all the acute kidney injury, you can see almost 27 of 233 were associated with NSAIDs. Definitely, there is other medication. I mean, we know a lot of medication, a lot of antibiotic we have to use in the hospital. Some of them nephrotoxin. And again, I wanted to make sure like NSAIDs, there's like, especially with this one, there is like two way you can get acute kidney injury with NSAID. So you can get the more typical way we know, which is like dose dependent. And this is much more commonly happened if the patients are dehydrated. So again, and that's the most common scenario we see for NSAIDs acute kidney injury, is somebody who's been sick, vomiting, fever, not able to drink, and they're already dehydrated, and then they're getting more like NSAIDs consistently, and that's usually the scenario we see. Every now and then we see what we call like acute interstitial nephritis, which is not dose dependent and it's not dehydration associated. And a lot of those patients maybe got like 1 or 2 doses and they still have significant kidney injury. And as I said, that's kind of like the interstitial nephritis is kind of like an allergic reaction. So again, like 1 dose is enough. And again, sometimes it could be confusing because one of the only way we can tell which one is which, sometimes we'll have to do a kidney biopsy, and we don't do like a lot of kidney biopsies for just acute kidney injury unless it's not following a certain pattern. So we know like we hope like it should improve with time and patients feeling better, but like the kidney, the creatinine stayed higher and is not improving. A lot of time I will think about acute interstitial nephritis at that point where the injury is not following the common, where we see it start improving after a couple of days. So the amount of nephrotoxins we use is also important, like at the same time. So this studies look at like percent of AKI, and you can see here is the number of how many nephrotoxins the patient is on. And you can see, I mean, if you're on one nephrotoxin, it's a little bit higher than if you're on none. But once you get to like 3 and more, up to like more than 5 nephrotoxins, the risk of acute kidney injury and hospitalized pediatric patients go significantly up. Excuse me. So now we talked about some of the risk factor. I want to take a moment to talk about like different AKI classification. So this is the most widely classification of AKI, which we're all familiar with, the pre-renal, intrinsic, and post-renal. And to this day, I really think this is the best way to think about a different type of AKI. And when I'm thinking of workup, I think this is the best way to do it. Pre-renal, we know it's like volume responsive, or what we call it functional AKI. So a lot of people actually advocate like we shouldn't call it actually injury because the kidney is doing its job where it's decreasing the urine output when you are dehydrated. On the expense, your creatinine is a little bit higher. And usually it could be from hypovolemia, so that's we see a lot in kids, dehydration, like gastrointestinal, like diarrhea or vomiting. Sometimes we could see it with like cutaneous losses with patient with burns, urinary losses, patient with like a dysplasia or something, that's where they cannot concentrate their urine. And then every now and then we see like it's just the patient actually fluid overloaded, but their effective circulation, the amount of fluids inside their intravascular space is not enough or not good. And that's, you see it in like septic shock where they get like leaky vessels and most of the fluids leak outside the vessels, cirrhosis, heart failure, even nephrotic syndrome, the same thing. Intrinsic kidney disease, so again, it's structural damage to the renal parenchyma. Again, that's include many different things. I always like to think about it as like different things. So you have the glomerulus, like glomerular disease. We have tubules, that's the tubular injury, like ATN, the most common type of acute kidney injury we see in the hospital. But it could be the interstitium, as we talked about the interstitial nephritis, or it could be even the vessels like vasculitis, lupus, and Henriksen line purpura and other things. So those all included in the intrinsic kidney disease. And then post-renal, especially among us who take care of a newborn, a lot like congenital anomalies, ureter obstruction and posterior urethral valve, and all of that urinary obstruction lesion could lead to post-renal acute kidney injury. And usually the treatment for that is calling our colleagues in urology and see how we can manage to overcome that obstruction. So now we talked about AKI. So I mean, we've been talking about like AKI, risk factor, all of those things. It's like why it's important. So again, we said majority of patients would recover, but it's not always the case. So we have many complications of AKI. So this is I'm here looking at a patient hospitalized with AKI, and you can see that mortality increased 15.3% compared to patient who did not have AKI. And if you look here, I mean the hospital, like patient had AKI, did not have AKI, uh, younger, like older than 1 month of age, younger than 1 month of age. They break it down: patient who needed dialysis, patient who did not need dialysis, and they break it down by patient in the ICU and outside the ICU. And you can see, I mean, a patient with no AKI is much lower. Again, if you're younger, if you're less than a month old, the length of stay is significantly longer when you have AKI, and mortality is much higher. And it makes sense also. We know patients who require dialysis have increased risk of mortality and probably longer stay in the hospital. So it's not just we like it's important. So as I said, the majority of patients will recover, but definitely acute kidney injury is associated with high mortality rate and definitely longer hospital stay. So again, this is the same study I showed you previously about the 24 collaborative neonatal kidney collaborative. So they looked at this patient and they looked at survival time. So they looked at death and they looked at length of stay for different stages of AKI as defined by the KaiDIGO criteria. And you can see patient with like stage 3 and 2, they had longer hospital stay, they had higher risk. And again, even with stage 1, you have higher risk. And they looked at Kaplan-Meier plot. So this is survival time. With time, this is the survival probability. So the dotted line is the patient with acute kidney injury. And you can see as we move forward with time, patient with AKI, their survival probability just go down compared to patient with no AKI. Uh, so again, this is the same picture again. I don't want to go through, but again, length of stay, study after study showing length of stay is much longer, and mortality. So this is the main two things we worry about when the patient is admitted in the hospital. But let's say yes, patient survived the acute kidney injury and the patient was discharged home. So now what's the consequences of that? So many studies showed, so patient with acute kidney injury, and again, the more severe the kidney injury, you'll have the higher risk of this complication. So they are at higher risk to have chronic hypertension, proteinuria, chronic kidney disease, and we'll talk a little bit about that, why is that as important. So this is long term. This is looking at like patients less than 18 admitted to the PICU. You have almost 2,000 patients developed AKI, and then later on they followed them over the year. And again, the solid line had no AKI, stage 1 AKI, and stage 2 and 3 AKI. Looking for incident of hypertension in those patients, and you can see the higher the stage of AKI, after 4 years, it was significantly higher risk of acute of hypertension. Um, Again, I want to share also this slide with you. This is like population-based studies done in Canada. And again, they looked at thousands of patients and they're trying to see patients who were hospitalized like age 0 to 18, received dialysis for acute kidney injury, and they matched them with just hospitalized patients who did not receive like dialysis for acute kidney injury. And again, they looked over the years, and then they had like almost 9.6 years follow-up for all those patients. And then they looked at kidney failure. The incidence was like 9.6, like that. The adjusted ratio was 2.96, so much higher. Major adverse kidney events was also higher. Major adverse kidney events mean like they required dialysis again, like they required hospitalization and dialysis again. They have chronic kidney disease. It was definitely higher, and de novo hypertension, as we talked about, like it's just start new onset hypertension, was also significant. So it is important when the kids are admitted to the hospital, so they definitely have higher risk of mortality and higher longer stay in the hospital. But it's not just that. Even after they go home and they discharge, and we say like they survived this acute kidney injury, they still are at higher risk for chronic kidney disease. They're at higher risk for hypertension and in the future. So now we talked about why it's important to detect AKI. Some of the things we can do to prevent AKI, so some of the things we can do and we know it works. So I try to put, we all know this. Again, administrating fluids, avoiding hypotension. Definitely, again, we said trying to avoid and replace some of the medication with some of the less nephrotoxic medication. And it is not easy to do. Sometimes there is no alternative, and we'll have to monitor and deal with it. But sometimes we have the option. So if we look at it and we want to, especially some of those patients we talked about before, where we know they fall under that high risk for acute kidney injury, that's something we may want to consider looking at what medication they're on and see if we can do anything about it. So I wanted to share with you, this is like kind of quality improvement project. They call it the Ninja program, which is nephrotoxic injury negated by just-in-time action. So basically, what they did, okay. So what they did is they found like a protocol with the pharmacy. This is this hospital. This study was done in Cincinnati children, and they looked at patients who are receiving 3 or more nephrotoxins. They build it in the EMR, like what's constitute nephrotoxins, and if anybody outside the ICU, because ICU patient is a little bit harder to change the medication because a lot of those patients are much sicker and they need their medication. But if you have somebody on 3 or more nephrotoxic and not in the ICU, or if they're using aminoglycoside for more than 3 days, there will be an automatic alarm to the pharmacist in the EMR. And then the pharmacist during rounds will suggest, oh, let's check creatinine, let's do this, and let's change the nephrotoxins if it's possible. And again, there you can see this is like AKI dates by nephrotoxic use. And then after they substituted this, you can see like how their AKI days significantly drop. And since then, this Ninja, it's still like many other children's hospital trying to adapt certain similar like protocols where if you are on like using EMR to get notification, like if you're on a certain amount of nephrotoxin or for longer than certain period of time, you get an alarm and then you can look into it a little bit further and see if you need to do anything differently. So hypervolemia, as we talked about, like hypervolemia, it is by itself associated with increased risk of death and acute kidney injury. Again, we always, it's reasonable when you have hypervolemia to try to induce diuresis by diuretics, but a very common misconception that like diuretics will treat or worsen the acute kidney injury. It doesn't change the course. All the studies was done on diuretic use and acute kidney injury. It didn't change the course or the natural course of AKI. Like you're going to recover when you're going to recover. But it may help you with the urine output, like increasing the urine output. And all of us who work, see patient, hospitalized patient, it definitely makes a big difference if you don't have to restrict somebody's fluid. Like it will allow you to give medication, nutrition, all different things. So that's the role of diuretics. But again, it doesn't change the outcome of the acute kidney injury. One important thing, it requires higher doses in renal failure. So as we know, all diuretics works on the nephron, on the tubule. So they usually secreted with the GFR, with the filtrate, and goes to the like activity place or activity location, like that loop of Henle or like the distal tubule. So if your GFR is lower, not much of the medication is arriving there. So you need a higher dose of diuretics to work in acute kidney injury. I just had like one slide as well about like when we do dialysis. Again, there is 3 different type of dialysis. So we have hemodialysis, peritoneal dialysis, CRRT, and a lot of time it depends on the hospital. Like some hospital feel more comfortable with different modality of dialysis. Common indication, again, there is many indication, but common indication, fluid overload that did not respond to diuretics. So again, dialysis at that point will allow you to give the medication and nutrition and blood products to your patient. Hyperkalemia, if it's not responding to your medication. Uremia, I put 80 to 100. To tell you the truth, if you probably survey like 10 nephrologists, you'll get like different answers. But most people will say like once you get up to like 80, probably you need to do something about it. But and then especially like if you have complication of fluid overload, you definitely need. But there is many other indication like intoxication. Sometimes we deal with inborn error of metabolism, and you need to clear some of those products out. So there is other indication, but those are the most common indication of acute or using renal replacement therapy. And again, all of them are used in kids. Again, that's like a whole talk by itself, just like renal replacement therapy in children. But again, we have a new advancement. So we have smaller filters for CRRT that's a little bit more compatible with our younger patient. Uh, Again, it is improving. I mean, it's I will not say like rapidly improving, but I mean we have more like newer machines now, more kids friendly and like more even neonate friendly compared to before. So lastly, I just want to talk about some of like the investigational biomarkers. So we talked about creatinine and cystatin C, but this is like a newer one. And again, it is now commercially available in some labs. I mean, at UMMC, we still don't have it. But again, this is something that's just starting, like at least in the last 6 months to 12 months, you start seeing in some patient, like in some hospital. It's still not commercially available like at LabCorp or Quest, as far as I know. Last time I checked, but again, so one of the main one I want to tell you about, it's called NGAL, or neutrophil galatinase associated lipocalin. So usually it's upregulated in the kidneys after an ischemic injury. And depending on the level of it, you can differentiate like pre-renal from intrinsic or acute tubular necrosis. And usually it goes up within hours, like 1 to 2 hours, and you can have some kind of like a marker for acute kidney injury. And again, this is important because if you remember, we talked at the beginning, like creatinine may take like half a day before it's going up. And again, let's say patient had surgery, like a congenital heart surgery, or any kind of event that we know it may cause AKI, and we don't know like did this patient have acute kidney injury or not. And then we're gonna wait until the creatinine go up before we do anything. Versus if we look at this, uh, and we see like no, this marker is elevated 1 or 2 hours after the surgery, I think we can do much better intervention. Like we can make sure like this patient doesn't take like more nephrotoxins. We can pay a closer attention to their fluids and make sure they well hydrated, to try to uh, to uh, to help a little bit with the acute kidney injury. So that's the whole reason. Like if you detect it a little bit early, it would definitely be helpful. So as I said, this is one of the most promising. There probably, if you look at the literature, there is like 15 to 20 new markers that have been studied. But I think this one is the one of like it's getting to the bedside sooner than others. So hopefully in the near future we'll have more tool to tell which patient is going to have significant kidney injury versus which patient will not have significant kidney injury, and hopefully we can have a better idea on what to do with those patients at that time. So this is my last slide, and I think we always get that question is, um, so we talked at the beginning about like detection of AKI, and we talked about like why it's important after we patient got AKI while in the hospital. We know why, and then once they're discharged, they're at higher risk of complication, and some of those complications are modifiable. So basically, it is important to detect AKI, and it is important for to have that AKI charted in the patient problem list after the patient is discharged from the hospital. So the primary care physician know this patient had this complication, and then they can follow up. So what we do for our patient, like definitely anybody who requires dialysis, we see them in nephrology clinic after. Anybody with severe acute kidney injury, we try to do like any stage 2 and above. We try to at least like follow them up 1 or 2 times in nephrology clinic. But again, it's not sometimes it's not possible to catch all the patient and see them. And again, Follow-up would include probable blood pressure check because, as we said, those patients are at higher risk for hypertension and chronic kidney disease. So what I usually do, I'll get them to clinic. I will check their blood pressure, make sure it's okay. I'll do a urinalysis, make sure if they have a proteinuria or not, because proteinuria and hypertension are the two earliest signs of chronic kidney disease. So, and they are modifiable. So we have some tools on our box to treat that. So we have ACE inhibitor, blood pressure control, and multiple study is known for CKD patient. If you control the hypertension and proteinuria, you will slow the progression of CKD, and you may buy the patient years of being dialysis free if you're able to know. But you need to know that patient had AKI before you can do anything, and that's why I think it's very important to make sure like we document that AKI when it happens, so at least the patient's primary care physician is aware of this and can implement some monitoring to try to avoid unfavorable outcome for the patient. So I'll stop here to allow some time for questions, and thank you so much for letting me talk.